Hello, Julie Bindman. I am so excited to be sitting with you today. Welcome to our podcast, Misconceptions.
So happy to be here. Thanks for inviting me, Devora.
Absolutely, absolutely. So, Julie and I have met each other professionally and personally, and has Julie, for me at least personally, has been a source of strong inspiration and guidance, especially when I was doing my training in EMDR, but also in some of the more complex casework that we've done over the years, and specific to termination for medical reasons. And this has been an area that we'll talk more about over the month of conversation on our podcast. But I really wanted to launch this conversation to set the stage about what does it mean to terminate a pregnancy. And I feel like I'm going to the expert to have that conversation. So before we get into the conversation, Julie, tell the audience who you are. Tell us what you do professionally.
Sure. So I consider myself to be a reproductive psychologist, which is a space that I've been inhabiting in for about 13, 14, even a little more years, but it has been broadened for the last 13 years. Prior to that, I was mostly doing a lot of postpartum kind of work, which of course still counts as reproductive health, but different piece of it. And I am a psychologist in independent practice. I co-own the practice, which is called Integrative Therapy of Greater Washington. It is outside of Washington, D.C. And I do a whole lot of a whole lot.
I know you're very involved in Jefferson and the infertility conference that we have once a year. And perhaps just to like set the stage in terms of education, beyond being a psychologist, when you call yourself a reproductive psychologist, what does that mean for the masses? Helping people understand your training.
Yeah, and it's a really good question because most graduate programs don't have any classes on reproduction. I know now there's actually like something that's changing at Rutgers, which is fabulous because a friend of mine is now chairing that program. So that's super fabulous. But for most of us, we get no training. It's not even mentioned. Maybe we've taken a human sexuality class, but
Right.
other than that, we are not talking about normative reproduction, and we're not talking about when things don't go the way that we expect or plan them to go, which is so common for so
Right.
many different people for so many different reasons.
Right.
So in terms of training, it started off pretty piecemeal where I was trying to do online and in-person trainings wherever I could find them. And oh my gosh, there are more now, and there still are not many.
Correct.
Um, and then I found that happened to be local to where I was. And at the time, it only did in person. So that worked. A year-long in-person training. I got 2 more years of monthly consultation. I joined ASRM and MHPG. So just for those that don't know, the American Society for Reproductive Medicine and their mental health professional group. I've taken the classes that ASRM has. I've been going to this conference, Jefferson, which is now the Jones Institute.
I saw that. I saw that.
Yeah.
Amazing.
I've been going since not its first year because I had just had a baby then, or I was about to have a baby, and the timing just was not going to work. But ever since its second year, so I've not missed a year.
Right.
So I get continual training there. I get continual training at ASRM. I learn, I try to learn from anywhere I can learn, and there's not a whole lot. So I created my own year-long course so that people can get what I hope is good training. I
Right.
think good training, I've been told is good training, but
I have no doubt. I think what this speaks to is the idea of like, it's very easy on Psychology Today to just check a box and say, I treat infertility, I treat pregnancy loss. And I think that I just would wish people were more knowledgeable about asking the question of what kind of training does somebody have that calls them and that helps them be identified as an expert. To me, the baseline training has to be American Society of Reproductive Medicine's training. There are 18 hours for mental health professionals, and anybody who calls himself a reproductive therapist, reproductive mental health specialist must have that training as a baseline. So that's an opinion. Again, there's no like certifying agency that says to us, you must have. It's opinion. But let's kind of use that as like the baseline.
can I say one more thing too, which
Please, please.
creates more confusion, is that Postpartum Support International does have a certification what's called a PMHC,
Correct.
perinatal mental health certificate. And I think a lot of people conflate that with the entirety of reproductive health. And so I think
Correct.
it's also really important that just because someone's a PMHC does not mean that they have any training or experience beyond very minimal that's offered with PSI. So I think that's
Correct.
another piece that's also really important. I've done all the PSI trainings. I got trained by them before they had a PMHC.
Right.
Sort of
Right.
mixed on that because I'm like, what does that actually mean? But I think it's also hard because people can join ASRM and MHPG and they don't even have to be psychologists or mental health professionals. Like anyone
Correct.
can join. So
Right.
these are really important points, which is like, okay, how do you know the clinician you're working with knows what they're saying they know?
Absolutely. Absolutely. So I think, being an educated consumer, asking more valuable questions around what actual training have you done? You're not just a member of ASRM, you've actually taken at least those 18 hours of training. Okay,
Yeah.
so let's move into just kind of setting the stage about what we're discussing today. So we know that the 1 in 4 pregnancies will end in a loss. We know that that's from miscarriage statistic. We know that 1 in 7 to 8 couples will deal with infertility when we're talking about heterosexual coupling. We also know that it doesn't always end with a healthy, no matter what. We're talking about significant situations where a pregnancy does not result in a healthy birth or a healthy baby. And that's the conversation that we're discussing today. So there's many different reasons why a fetal development might kind of go wrong. It could be something that is from the shared genetics of the parents. It could be an issue that is in the actual development of that embryo. But here we are in a typical, pregnancy situation, and there are the testing happening around 10, 11 weeks or 11, 12 weeks. And then again at 20 weeks that give us insight into the development and the growth of this fetus. And when things go wrong, we have what we consider options as to whether to continue the pregnancy or to potentially terminate the pregnancy. Today's conversation, which is otherwise known as ending a pregnancy or an abortion. And we are discussing this specific to our conversation, is the discussion of when there is a termination for medical reasons. And for this conversation, just termination of medical reasons when there's something wrong with the fetal development versus something is wrong with mom. So,
Right. I was going to say that's a really important distinction too, that it can still be a termination for medical reasons if mom is unable to sustain being pregnant. And there are lots of comorbid kinds of syndromes where it might not be, or there can be a cancer diagnosis where it's not safe. Like if in order for
yeah,
mom to get treatment, mom can't stay pregnant. So I just
correct.
want to put that out there too, because I think that's really important. And I think it is a place of invisibility that when people terminate an otherwise healthy baby, but for medical reasons that relate to their own health and well-being, I think that feels even harder to
For sure.
be part of a community or to be understood.
And I think what's interesting is when I know that we're talking, many of the individuals will be listening to our podcast today will be hearing this from a Jewish or religiously Jewish perspective. And so I think that perhaps in the religious world, it's a little bit easier for that scenario to be understood in that religious law dictates the idea of the primacy of the life of the mother over the life of the fetus. And so that idea of we may have to terminate a pregnancy because mom is sick is way more understood, I think, than the frequency in which pregnancies are being terminated because of abnormal fetal development. And so that's where we're kind of like narrowing that force of conversation into this area.
Well,
So
it is the only faith that looks at it from that place. It's the only faith group that can understand
yeah,
that the person who is pregnant, their life is valuable.
correct.
And that
Correct.
if they're suffering there, we don't just, well, we'll just pick up by our bootstraps and grin and bear it. Like, no, we end
Correct.
suffering.
Correct. And to recognize as well that the concept of TFMR also exists when we're dealing with mental health as well as medical. So it's not only a cancer diagnosis or something medically wrong with the parent. We're really also acknowledging that mental health is coming into these rabbinic, halachic, Jewish law decision making where mom is not well enough or mental health stable enough to carry this pregnancy to term. Again, these are incredibly complex questions that are in
Yes.
major levels of discussion rabbinically and with families. But I think the greatest value of this is to say, these are happening, these conversations are happening. I think if you would have said to me 20 years ago, do Orthodox Jews perform abortions? I'd be like, no, absolutely not. It's totally not allowed, except for the life of the mother. And boy, have I come to understand quite differently in working within reproductive mental health.
Yeah,
So,
absolutely. Yeah.
so Julie, tell me, if you're willing, whatever parts and pieces you'd like to share. I know that you have a personal story related to TFMR, and wherever you'd like to start, I'd like to hear your story.
Sure. So I'm going to keep it super, super, super brief, because we could spend the rest of the podcast just talking about my story. And while I'm happy to do that another time, I would love to talk about all the nuances in it. So the really super brief version is that I had had a healthy baby. We wanted to get pregnant again. I had experienced a miscarriage. I got pregnant afterward at 20 weeks. We learned that there is a fetal anomaly. We learned that the baby didn't have most of a brain, and we were given the option to abort or we could carry to term. And we chose to abort. We did consult with our rabbi, and she was fabulous both during and afterward. And then we were told this was probably a 1 in a million, not likely to happen again. Go ahead, just get pregnant. We'll monitor you if you wish, and go on with our lives. So that's what we did. And I got pregnant again. And at this time, because we were looking a little earlier, at 18 weeks, I learned that the same brain anomaly was occurring in this new pregnancy. And so once again, we decided to terminate for medical reasons, to abort. And at this point, we started to get lots of genetic testing and trying to understand, why is this happening? And we didn't find any actual reasons. So IVF wasn't really an option unless we just wanted to spend money to spend money. So we were basically told, get pregnant again, we'll monitor you, we'll do a MRI at 18 weeks, and we'll go from there, which is just what somebody wants to hear.
Yeah.
And I'm coming up with all of these ideas and thoughts. Like, I was problem solving in a way that made sense as a way of problem solving, but now that I'm really in the field doing this work, I'm like, oh, those were terrible ideas. So like at one point I'm like, well, let's just create embryos and we can have a gestational carrier and I can get pregnant. Like, it was, whoo, we went down. As I said, I was problem solving for problem solving. And these are ways of problem solving, but they would not have been emotionally healthy ways to do it, for lots of reasons, the way I wanted to do it. So I want to be clear, I'm not saying using a gestational carrier isn't emotional healthy, but trying to do that and to be pregnant at the same time and to have to deal with potentialities of it was just not a good idea. So we got pregnant again and we went in for an MRI at 18 weeks. And we learned that this time I was carrying a healthy baby who ended up being growth restricted and born at 36 weeks, but is now about to become a mitzvah, a b'nai mitzvah. Super excited.
Wow.
And then we were like, let's just roll the dice one more time. And we were very fortunate and lucky that I had a third, or actually it was a sixth, but a third living child and an uneventful pregnancy then too. And he is about to be 11. So
Wow.
that
Wow.
is when we decided, cool, we're done.
Right. Right.
Let's not tempt fate anymore.
So just to clarify, when we talk about genetics, and this is something that we'll have in a future conversation with a genetic counselor, but sometimes I think we see genetics as like it's A plus B plus C, like it's just the chromosomal abnormalities or how they present. But to recognize that some of the chromosomal testing, for example, when we do pre-transfer, pre-genetic pre-implantation genetic testing of an embryo, for example. Somebody's going through IVF, they test the embryo, they look to see if it's chromosomally normal. In a typical PGD type of testing, we're looking just to see that the proper number of chromosomes line up. That's different than if somebody is a known, perhaps, carrier or has, strong prevalence in the family of things like Fragile X or Tay-Sachs or anything like that. Then they're looking for a specific presentation of illness. Right. And then we have chromosomal abnormalities that we have no idea why. Like we don't know where it is on the chromosome to find it.
Right.
If there is one.
The best way it was described to me was actually last ASRM, where they talked about, if you think about the chromosomes being like, and you got to be old school for this reference, is like encyclopedias, right? In the old school encyclopedias, you had volume like A through AK, and then AK through, you know,
Right.
whatever the next one was, and then maybe volume B and volume C. And and so if you think about those volumes, those are the chromosomes, right? So just because we have all the chromosomes present doesn't mean that what is inside, all the genetic coding, is necessarily written in the way that we want it to. So if you open up volume B and you're like, wait a second, we're missing the whole section on boa constrictors. Why is boa constrictor not in this volume? So that just shows like there was a misprint, or, oh my gosh, there's two sections of boa constrictors, or whatever else, or wait a second, we have something totally different that shouldn't be here that's here.
Right.
So that, I think, is an analogy that
It's
makes it
excellent.
a little more understandable for people, that it's
Right.
not chromosomes. So I think a lot of times people will do, and me myself, I had all the chromosomes were great. We had
Right.
that kind of test. We had screenings done and
Right.
came out looking great. And
Right.
that was
Right.
not.
And that's something I think that always speaks to that like pregnancy loss experience where people who have gone through a pregnancy loss will say, oh, well, we had the it was genetically normal. And then I'm thinking to myself, it's genetically normal, which means it had all the chromosomes. But using your analogy, we don't know that everything inside those chromosomes were actually healthy.
So I correct people. I say it was chromosomally normal.
Got it.
Yeah,
Excellent. Yeah,
because it was.
exactly.
Yeah.
Right. Right. Okay. So when we think about the process of termination from a first person account, can you share a little bit about what it was like to either to be told that you have the option or that you need to make a decision? And also like just what that was like, maybe either between you and your spouse or between you and your physician. What was that experience?
Yeah. So, um, and what's so interesting is like my experience is now 14 years old. And so it looks really different today. And yet, even in my experience, there were some nuances that made it hard at that time. So we were told the Friday before Thanksgiving, we had gotten testing results back, or we'd gotten ultrasound results that, in fact, not everything was proceeding as expected. We did a follow-up the Tuesday before Thanksgiving where we had a lot of different kind of testings, including an amniocentesis, just to try to get information. Over the weekend, as I mentioned earlier, we called our rabbi and we were talking to a genetic counselor, several of them, in fact, and we had met with a neurosurgeon. Like we met with people who could talk to us about, if you choose to carry to term, this is what it will look like. If you choose not to, this is what it will look like. And the timing of that termination was actually 6 months after George Tiller, who was a physician in Kansas, was brutally murdered outside of his church. And he was one of the second and third trimester abortion providers. So this was a really big loss because people got scared. So I was only 21 weeks in my state. It is legal. There were plenty of providers. And once Dr. Tiller got killed, people got scared and they stopped providing this kind of service. So no one in my state would perform a surgical abortion.
Hmm.
I was told that I could travel to a different state and I could have a surgical abortion, or I could labor and deliver in my local hospital and that my normal OB could attend to me. So at that point in time, like I just wanted this to be done. I didn't want to be carrying, like it felt a little bit like this was somebody waiting to die that was inside of me, like as if someone was serving like a life prison sentence and they're on death row. So like I just felt like the baby inside of me was on death row and I just wanted it to be done. And I don't mean like that is a very stark kind of image, but it was so painful to me to feel him move and to feel him seemingly be healthy and he wasn't, and to know that he wasn't, and to know that all the dreams that my husband and I had for him and had for our living child were just not going to come to fruition at this time. So I was really fortunate. Before my husband and I got married, we actually talked about what we would do in a situation like this. And I don't know how that came about. It came about sort of randomly, and
Not
we
the
just
typical
had a
first date conversation.
well, it wasn't a first date at least, but it was as after we were engaged, we started to talk about
Wow.
that. And we both at that time were like, oh, we would terminate. And it was kind of funny because at that time, sort of the worst thing we could imagine was like, what if it was a chromosomal issue like Down syndrome? Because that is the one that I think we are all exposed to, because
Right.
typically other chromosomal anomalies people can't survive. So that was sort of what our limited reference was. And so we had talked about it, and that's where we came out. So when we got into this situation and we were learning about quality and quantity of life, and those are frameworks I like to give people because I think they're very different, right? That you can have a really rich life for a short period of time, or you can have a very long life that is very empty. And so I think both of those are really important factors for parents to consider. So we just made the decision that given everything we were told that best case scenario, the baby would have the developmental quality of life of a 2-month-old, that he could live into his 40s or 50s, that he would always have a feeding tube, he would never speak, he would never walk, he would have to be cared for 24/7. The good news was he could swallow. So it was like,
Mm.
and it just wasn't a life that we envisioned for ourselves, for our son, or for that person. So that was a lot of the conversation that we were having was around that. Um, Given where our choices were, I didn't want to travel.
Right.
um, and our option was New Jersey was the closest place to go. And I was like, really the last thing I want to do is to be around strangers and be around people I don't know in a place that I don't know. And if there's any kind of complications or anything, and I don't want to have to sit in the car after having surgery, like none of that sounded good. So we decided to labor and deliver at my local hospital with my OB. It was, of course, the day after Thanksgiving. So we had all the good staff. That was,
Oh
um,
boy.
oh boy, is a whole other thing. So that's kind of how we made the choice. And it was what was available to us at the time. I was too far along to do any kind of medication induced abortion. Um, the surgery is called a dilation and evacuation, a D&E. I was too far along to do a more common D&C. There are fewer people trained to do D&Es, so that's another part that's really hard.
Right.
Um, and another misconception, since that is the name of the podcast, is that you don't have C-sections typically for this. Like they
Right.
want you to have a vaginal birth. And because the Pitocin receptors aren't even there yet, because most of us are not far enough along for them to come, it is a several day process to labor and to deliver.
So can you differentiate between laboring and delivering versus the D&E? So I'm hearing you said that you had a D&E or you had a labor and
So I labored
delivery.
and delivered, but my second loss, I had a D&E. That's
Okay.
why I know
Okay.
both about, I know it about both. Um,
Right.
so the labor and delivery is I got induced. I was given Cytotec, which is a medication to ripen the cervix and to get labor going. That was given to me vaginally, just to try to get things going. It took a good 24 hours for me to fully labor and deliver. At the end, my placenta wouldn't detach, so I ended up needing surgery. I had to have a D&C
Oof.
anyway.
Anyway. Yeah.
Um, and just being in the labor and delivery ward while everyone else is getting their screaming, happy, healthy babies, and we were the sad room, and
Yeah.
there was a picture denoted on the door of the hospital, or of our hospital room, that denoted that we were the sad room. So
Hmm.
like I
Hmm.
had someone walk in and they're like, how are you? Like I sort of saw
Right.
sort of change tack, and
Right.
I'm like, yes, we are the sad room. Do not come in and be like, how are
How's the
you?
new mom? Right. Exactly.
I'm terrible right now.
And
So
what were some of the considerations that the second time that you had to go through this, that you chose a different route?
Well, I had a terrible labor and delivery. Um,
Okay.
and that was not on my doctor. She was fabulous, but I just didn't
Okay.
want to, like, it took so long. I didn't want to go through it again. And because we had determined this earlier gestationally,
Yeah,
a
and more
date was
options.
available to
Hmm.
me. It wasn't
Right.
available to me unless I traveled, but it was
Right.
available to me without me having to go anywhere. And the doctor that I was with was incredible and just really kind and generous with his time. So he was the one that performed it, and it made me getting to healing happen faster, but
Hmm.
it doesn't mean it was easy. Like I'm trying to sort of differentiate that. Like there was
Right.
benefits to going through the labor and delivery because it really gave me time to be like, "Ooh, this is really happening." Whereas like surgery is like, "Cool, I'm going to surgery," which is sort of a more mechanical kind of point of view around that. Um, Labor and delivery, had I wanted to spend time and hold the baby, I would have had those options to do. We chose not to. We were given the options and we chose not to. So just I think it also depends too upon what is important to you in terms of
Sure.
after.
Right.
Did you want
Right.
footprints or do you want kind of mementos or any pictures or things like that?
Right.
That is only available if you labor and deliver.
Is that something that was important to you? I know that you chose not to see the baby, but was it important for you to have those mementos, the handprints or footprints or anything like that? It wasn't. Hmm.
It was not, no. The way my husband encapsulated it, which I thought was a really useful way of thinking about it, is he's like, this was a body, this was a shell, that the soul of our child is still out there, and we need a healthy body for that soul to go in. But this was just a shell. There was no soul there.
Hmm.
This was not our
Hmm.
baby. Like this was,
Right.
this didn't work. So
Interesting. Interesting. Yeah. I mean, and obviously recognizing and acknowledging that there are definitely differences of opinion and perspective, and many, many, many women and couples really feel very strongly this is their baby. This is and represents way more than that, or differently than what was, than what your perspective was.
so that was his perspective. I've always called it my baby. Um,
Mm,
and I think because again, this wasn't work I was doing, it just felt so morbid. And I was concerned because it was brain anomalies. And like,
mm,
I think it was more, I was worried about not being able to unsee what got seen.
right.
Um,
Right.
I
I'm
was just,
curious now that you're doing this work, do you have a different way of approaching the clients that you work with? If that becomes a fear of a client.
yeah, I mean, I can speak to them in terms of what research says, and what I try to do is I'm like, look, at the end of the day, you're making the best choice for you based upon what you know in this moment, and you might
Right.
know things differently that, you know, are not what you know at this moment, but
Yeah.
this
Yeah.
is what you know at the moment. Um, because I think about it, I'm like, would I have wanted to do things differently? I don't know that I necessarily would. Um, I Yeah, in terms of my relationship with these babies has evolved over time, but it's always been a relationship, and I yeah, I'm not sure that that would have been a right choice for me, and it is
Right.
very much the right choice for so many people.
Right. Tell me a little bit more about that use of the word relationship with your babies. I think that's a fascinating term that many of us use. Even just the concept of having a relationship with somebody who has died. Talk to me a little bit about what it means for you.
Yeah, I think after I finally had my second living child, like I was able to, again, the relationship with the baby shifted. So it wasn't that I was mourning something I wanted and mourning this future that hadn't been attained by me, but because that was part of it. It was mourning the what if, it was um and being angry that they weren't healthy. I mean, there's so many different pieces, and all of it is being angry with God, very angry with God. Like, why? Not only once, but twice. Like, what is that? Why?
Sure.
Why?
Right.
Um, but I think it was always in relationship with whether it was with God or my husband or these babies, and just trying to understand, like, okay, I am your mom, and part of my relationship with them was I was not going to hide them. So I talk about them all the time, and I'm really open about that. And I've gotten into different kinds of volunteer work in terms of just sharing this story, because it's really important to do so. And so now I look at them more as I learn from them, right? I learn that like, oh, this is this whole world that's opened up to me, and I learn how important it is to be able to even have this choice. And I don't think in 2009 it fully set in how lucky I was to be in a place where, yes, this was an option, and even if we can't do surgery, we will figure it out, and you will have options, and we will
Right.
make sure that you have options. Versus today, I mean, like, we think about it, and it was just, I don't mean to timestamp this, but even this week that we are recording, a woman in Texas was denied by a court an abortion because of trisomy 18, a chromosomal anomaly. Her baby is not going to get better.
Right.
There is no cure. Her baby is going to die. Her
Yeah.
health is going to be at risk for that.
Mm-hmm.
It already was. And
Right.
she was denied, like, to have to humble yourself to go to a judge, even though your doctor's like, you need an abortion, like,
Right.
this is what needs to happen. And to have a judge be like, nah, you're okay, you got this. And so it meant that she had to travel away from home. Like, she didn't even have the option to
Right.
work with a
Right.
doctor that she knew and
Right. And I think, and I want to like pin that, let's just put a pin in that piece of this, because one of the things that I think is so profound is we're very accustomed to having the option when, let's say, for example, when the rabbi says you really are going to have an abortion because your life is at risk, what people are not realizing is that these laws are going to so deeply impact the religious world, where rabbi says and doctor says, I can't help you, or legally, I can't help you in doing this. And so even when it's medically required, necessary, and rabbinically, sanctioned, these laws are going to be impacting the communities in which we live. And that means putting the lives of the mothers in those circumstances, specifically the lives of the parents, at risk. And that doesn't even address the fact that many of the families in which I'm working have received rabbinic, kind of permission to terminate pregnancies for fetal anomalies. And this will impact them as well. That inability to access the care that they need in their own environment, in their own with their medical providers. And that, again, such a broad conversation. But what I am wondering is, what's it like for you as a person who had to go through this, to know all of these limitations of 2023? Like, how does that feel for you, having had the opportunity of choice and then knowing that today things would probably look really, really different?
So here's the thing, they wouldn't have looked different for me, because I live in a place where my state has gone through great lengths to protect abortion.
Right, right.
So I think that, and I want to acknowledge that, like, I am in zip code privilege. Is that a thing? But I guess it
Right,
is.
right.
And so because I'm sitting in a place where this is still, I still have choices. I work with people all of the time, and they're able to have the choice. Do they have a D&E? Do they have a labor and delivery? Do they receive medication if they're early enough to be able to do so? Do they have a D&C? Like, all of these choices are available to people because of where we reside. So if I lived elsewhere, we probably would have traveled.
Right.
That's a whole other burden, like finding care for my son, and all of the other.
And the cost of doing this out of pocket, we're talking $10,000 to $15,000 on an average, for a medical, if you're lucky, right? Exactly. $10,000 to $15,000 for an abortion. Most people don't have that cash.
No one has that lying around, and you're not even including transportation to get there, a place to stay, because this is not an in and out procedure. Like, we're talking
Correct.
about 2 days where you're meeting with the professional, maybe the next day you're having the abortion. Not because of waiting things, but I think oftentimes doctors just want to sort of get a sense. They want to make sure they have your records. Sometimes you can just set it up and it is a 1-day thing, or if there are complications, it might be a little bit longer.
Right. Right.
So there's all these different
Yeah.
pieces that
Absolutely.
come in.
Absolutely.
So I mean, it's one of the work the lesson, I should say, that my babies have taught me is that I have a story, and I have different aspects of privilege, and I have a comfortability where I can share that story. And so that
Right.
has been something that I do, and I do it unabashedly and proudly, because I want their deaths to mean something, right?
Right.
I want,
Right.
I become a poster child. Okay, fine, but these things happen, and they happen more. They're still rare, but they still happen more than we think. They're
Most
not.
definitely. Most
Yeah.
definitely. So in light of the time that we have together, I wonder if we could talk for a minute about what you would identify as the top 3 misconceptions about TFMR.
Yeah. So one misconception is that while we use the word choice so much around abortion, I think that's a really hard word to apply to terminating for medical reasons. And it is where people that have terminated for medical reasons feel very separate from those that have had miscarriages or stillbirths or losses for any other kind of reason. Because what gets put on us is, well, you chose this loss. And it's like, no, no,
Mhm.
no, 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 no. I had two really terrible decisions to make, and I made what felt like the better of two terrible decisions. I was in a circumstance, and so it's not a choice in that kind of way. And yet also when we're talking about having the care accessible and available, yeah, okay, that framing of choice, I understand that.
Sure.
So I think that's a really important misconception to think about. We mourn our babies, that this is a very intense loss. We mourn who they could have been, who we expected them to be. We mourn if it takes us longer, or if we're not even able to have a baby afterward.
Mhm.
So these are babies that are very wanted and very mourned, very grieved. So I think that's another piece too, that again, it goes in with the choice of like, well, you made the decision. No, it doesn't mean that we're
Right.
anything that this is upsetting. Um, and I think another misconception is that you don't know what you would do unless you're in the situation.
Mm.
So, you know, I've met with people who have terminated for one thing and then have had a poor prenatal diagnosis and a subsequent pregnancy, but it was one that they felt like they could manage. And so they didn't terminate for that. So it is so case by case. Um, you know, it is something that will change your life. Like it can change your marriage, maybe for the better, but maybe not. It can be a really rocky time. It changes your relationships. If you have a family that is not supportive of abortion, then that is another kind of ripple effect of it. And how do you talk about it? If you're in a community that is, and there are Jewish communities who are completely unsupportive about abortion. And so that then becomes really difficult of how do you feel in community in those ways?
Absolutely. I think about also the idea of like, what is the story we're telling? So for you, are very public about the story, but I would say that most of the people I work with are very quiet about it and usually say it was a stillbirth or a miscarriage and really don't get any level of important support around this really complex decision making that had to occur.
Right.
And that's isolating, deeply,
Oh
deeply
my God.
isolating.
Yeah.
Yeah.
We talk about it with my clients, we talk about it as the two stories, right? Like there's
Hmm.
the public version, and then there is the story you tell that you're
Exactly.
trusted
Exactly.
through. Yeah.
Exactly. So there's way more, around that. And I think also just a question of, I hear in you a certain level of stability within your story, perhaps, or I don't want to use, I don't know that I have the right to use the word like a peacefulness or um, I don't know what word you would use to describe how you feel about your story. What I would say is that I think a lot of the people that, some of the people that I work with are not at that level, at
Yeah.
that, their experience is different. And there can be feelings of regret or I had to make this decision and I'm still in tremendous, kind of disarray with what happened to me and acknowledging that that also can be part of their experience.
Oh, 100%. I mean, I feel so, again, lucky is a weird word to put with this, but and both my partner and I have talked about this. Like we both feel lucky. We had a really clear diagnosis. There was no gray in it. There was no,
Sure.
well, the prognosis could be, like they were very clear that the best case scenario was pretty bad.
Yeah. Yeah.
So that was really helpful for us, is to be like,
Sure.
we are not in this gray, like we are very firmly in
And
the
the black or the white. Yeah. Yeah.
and so again, like that's another nuance of it, is if
Right.
someone's in more of the gray, I've worked with so many people who have circled back and was that the right decision and could that baby have been okay, and all of the things.
Yeah. Mm.
So really this topic needs longer than we've given it, and
For sure. For sure. For sure.
we can have more time another
I
time.
know. I'd love to. I'd love to. Julie, thank you so much for spending time with me today. And just really kind of like opening a window into something that is incredibly, incredibly complex. But I also believe it's something that most people aren't really giving much consideration to. They're not thinking that this is happening in our community. And these conversations will start that discussion. So thank you so much.
Absolutely.